Good evening, ladies and gentlemen. Take two. As you can see, I am proudly wearing my Bovember bow tie because November is a very special month for us at Procure. So welcome to Procure en Parle. And my name is Winston McQuaid. And as we all know, information is the first remedy. Procure is pleased to present you the seventh and last webinar this fall before the holiday season. So today we will discuss tests and examinations, as well as important role of PSA in facilitating diagnosis or in keeping an eye on your cancer during or after treatment with Dr. Daniel Lewinshtein, surgeon-urologist and head of the urology department at the Centre Hospitalier Pierre Boucher. Thank you very much, Dr. Lewinshtein, for accepting our invitation. We will have a presentation by our specialist, followed by a question period. And speaking of questions, thank you for those messages you sent to us in advance at info@procure.ca. Otherwise, if you have questions, you can submit them during this session using the Q&A button at the bottom of your screen. So before we begin, we would like to thank, as we do all the time, all of our donors from the bottom of our hearts, but also the official presenter of this webinar, Industrial Alliance, and also our partners, Astellas, Bayer, Janssen, AstraZeneca, Merck, as well as both the Quebec and Canadian Urological Association. So without any further delay, I now turn the floor over to you, Dr. Lewinshtein. You can now share your screen, please.
Okay, you can hear me now?
Yep.
Okay, perfect. Thank you for the invitation, Mr. McQuaid, and I hope I can be of some help tonight. So essentially, we're going to talk a little bit about prostate cancer, specifically screening recommendations. There was an update in 2022 on prostate cancer screening in Canada via the CUA, as well a little bit on the simple test to diagnose prostate cancer. And also we'll delve a little bit into the specific tests such as MRI, abdominal and pelvic CT scans, bone scans, and a little bit about PSMA, which is new on the horizon. And then, of course, the management and the role of PSA. And then at the end, I'll be here to accept any questions at all. So just a couple of brief facts. Obviously, we know prostate cancer is quite prevalent. And about 1 in 8 men in Canada will have prostate cancer. However, only about 1 in 29 will die from it. So in the majority of the men, either they are treated well or they are surveilled properly and they do not succumb to the disease. That being said, there's a huge amount of Canadians that do have the disease and a new incidence every year. So approximately about 24,000 men will be diagnosed in 2022, and about 4,000 of those will actually die from it. And if we look specifically in Quebec, each day there's about 12 Quebecers that are diagnosed with prostate cancer. So our goal essentially now as urologists, which has changed a lot over the last 20 years, is not to specifically find all prostate cancer, but to find the prostate cancer that we know has to be significant, which we know can cause morbidity and mortality in our patients, and to try and find that cancer and then cure that cancer. So specifically, people might ask, why screen? So the main goals of screening, specifically for prostate cancer, is to detect the cancer before it becomes metastatic and incurable. And specifically for prostate cancer, symptoms come late. So essentially, if someone has local symptoms, i.e. obstruction or bleeding, they're clearly locally advanced and unlikely to respond to good treatment. And if they have pain in distant sites, such as bone pain or other, they're metastatic. And at that point, although we can treat them, and we do have a lot of great treatments that have come out over the last 20 years, we don't have a cure for someone that has metastatic prostate cancer. So ideally, we want to screen them before symptoms. These symptoms, the common ones we know are blood in the urine or hematuria, as well as the retention symptoms, so unable to empty our bladders. Sometimes when the retention becomes so bad, patients can become in renal failure, or sometimes when people have specific prostate cancer that goes to the lymph nodes, those nodes can obstruct the tubes that come from the kidneys called the ureters, and that can also lead to renal failure. And then finally, as I touched on before a little bit, but obviously disease from the prostate going to metastatic sites of the bone can cause a lot of pain in a lot of patients, and as well as fractures and other associated morbidity. So essentially, the main test we use for screening is PSA. So the PSA test, it doesn't say it here, but it came around about 1989. It was invented in the US by a guy called William Catalona. And the idea was to screen patients with it. It's not a perfect test, but it's a good test in the sense that it's not specific to prostate cancer. So it's specific to the prostate per se, but all PSA is essentially is an enzyme or a protein that is inside the cells in the prostate. And when the cells die, they release this protein PSA and it goes into your blood. And with an assay in a lab, we're able to test the quantitative levels of that protein. And the thought process is that patients either that have infections such as cystitis or an infection of the bladder or prostatitis, infection of the prostate, urinary retention, anything that causes some type of inflammation or irritation or infection of the prostate is going to lead to increased cell death and subsequently increased PSA levels. As well, there's even some small augmentations in patients that have had a recent rectal examination, probably not significant, probably in the level of 0.5, we know from studies, as well as having sexual relations can increase your PSA mildly as well. The other study that we know about is cycling, and although studies suggest it doesn't increase PSA as much as we thought, I would say in my personal experience, a lot of patients of mine that do cycle, just by the very fact that the prostate is in the perineal area and that's sitting right on your seat. And if you're cycling from long times, you're going to get a lot of irritation locally and subsequent increases in your PSA. As well, people that have large prostates, so they may not have cancer, but they have BPH, so benign prostatic hypertrophy. So as all men age, testosterone, which is always secreted from our testicles, interacts with receptors at the level of our prostate. And that interaction occurs for the rest of our lives, and thus that testosterone induces a message in our prostate to grow. So as men get older, most men, about 60–70%, will have a larger prostate, and some men, that larger prostate will cause obstruction. And then ultimately, of course, we want to find the cases of PSA that are elevated due to a prostate cancer. That's our goal here. So what is good screening? So I can give you a little background on this, but screening in Canada started about 20 years now. So we started about 10 years after the PSA test was introduced in the US around 1990. And when screening did start, there obviously was a massive increase in the number of prostate cancer cases being found in Canada, in the US, and subsequent treatments. And at that point, 20 years ago, that was just before I was starting residency, we were treating everybody that had any type of prostate cancer, whether it was the lowest grade or the highest grade. And we were treating them with radiation or surgery or both. And of course, a lot of patients that had low-grade disease probably didn't need to have that treatment, but we didn't know that at the time. And so there was probably a lot of over-treatment and over-diagnosis. And that led to a whole movement within government, specifically in the US, what's called the USPTF, which is a task force that looks at proper screening. And at some point they suggested around 2012 that older patients should not get screened. And that around 2014, they said no patients should get screened. So suddenly they gave out this, this memorandum, and a lot of family physicians in Canada and the US started following their message. And so prostate cancer diagnosis went down overall, but the number absolute of cases of metastatic disease went up. And at the time, there was 2 or 3 large trials that looked at prostate cancer screening. And 2 out of the 3, one was a large American trial and 2 were European. Both European trials showed a clear diminution of mortality of patients undergoing screening. And based on that recommendation in those trials, screening was again recommended actually in 2017 by the American government, and Canada followed suit. That being said, the Canadian Urologic Association, which is what I'm part of, what urologists, we never obviously said to stop screening. We were always pro-screening. So there's been a balance between the message from urologists and the message from government and epidemiologists, but now we're sort of going in the same direction. I can tell you the COA specifically says PSA should be offered to men who have a life expectancy that's more than 10 years. This discussion with the patient should be a shared decision-making in the sense that the patient has to be aware of the risks of PSA, which is the anxiety associated with it, the constant testing once a year, once every 2 years, and also the risk to find a cancer that may not be significant. The guidelines now suggest starting at 50. We know that patients that have a PSA that's mildly elevated at 50, their lifelong cumulative risk is quite elevated. So a patient that has a PSA, for instance, under 1 at 50 has really no lifetime risk of having significant prostate cancer. However, if their PSA is even mildly elevated, we know even if we're not going to diagnose prostate cancer at that time, we know that that person's cumulative lifetime risk is greatly increased, and those patients merit good surveillance. We also know that certain patients are at higher risk. So patients, for instance, that have family history, so that's technically defined by 3 first pedigree family members. So 2 brothers, a father and an uncle, but really we don't always see that. We don't always get that perfect history. Patients may be adopted. So obviously if a patient comes in and they said, my father had prostate cancer at 55 or one brother had it at 45 or 50, based on that, we're going to consider them technically not hereditary, but we may treat them as such with respect to our index of biopsy or not. As well, we know patients that are of African-American descent have higher risk of incidence of prostate cancer, and specifically higher incidences of risky prostate cancer. So those patients should be offered screening earlier. We're also seeing over the last couple of years in Quebec, and we've spoken about this at our annual meeting, is that there seems to be some type of shift in the age at which we see prostate cancer. So we are seeing cases that are younger, whereas 15, 20 years ago, we did not see patients that were in the 47, 48, 50-year-olds. We are seeing those patients now. And so it really reinforces the idea that if we are going to do PSA screening, it should be started early. How do we do that? As I said, by a blood test, a PSA, a simple test that can be done in any laboratory in Canada, as well as a rectal exam. A lot of family doctors now will elect not to do a rectal exam. Maybe they don't feel comfortable with doing it. Maybe they don't believe in it. Surely, obviously, the rectal exam can only feel lesions that are at the back of the prostate or the posterior aspect, because that's the aspect of the prostate that's in contact with the rectum. And that is where the majority of cancers are. But there also are cancers in the anterior area where we could never feel it with rectal exam. However, the PSA should be elevated in those cases. So doing both kind of gives us increased sensitivity to find those cases that are there. So what are the advantages of the screening? I guess there's a reassurance that there is no cancer if you have a normal PSA. If you are diagnosed early with a significant cancer and you are treated, then you prevent the morbidity associated with metastasis and possible death. What are the disadvantages? Obviously, patients that are being followed with PSA, in certain patients, they don't worry about it at all, but in others, they're quite worried about their PSA. If one value goes up, they may be charting it at home. They may be checking online with various applications where it's going and where do they feel it might end up. As well, the biopsy itself that we would do for a patient with an elevated PSA is associated with some morbidity. So there's a risk in Quebec right now. The risk of transrectal biopsy causing infection, systemic infections, around 3-4%. The risk with transperineal biopsy, however, is probably around 0, which is a new biopsy technique which we're doing. And then the bleeding risk is around 1 in 200 patients that will require a transfusion, so quite rare. And I can say I've been in urology since 2004, so about 18 years now. I've seen, I think, 2 patients admitted to the hospital for severe rectal bleeding, but it can occur. And if it does, it has to be treated expediently. Of course, there's the question of overdiagnosis. So what I alluded to before, so patients that have a prostate cancer, there's not necessarily worrisome. That may be what we call low grade or Gleason grade 1. Those patients are overdiagnosed in the sense we probably didn't want to find that cancer because we know we're not even going to treat it. We're just going to follow it. And that patient that has that cancer obviously has some burden of worry because the word cancer. as well. They may not be eligible for certain insurance products based on the fact that they have a cancer. There's that aspect. And then obviously, if they were to get treatment, there is the question, it's happening less and less now, really, but 20 years ago, all prostate cancers. So the low risk prostate cancers we were treating, even the what we call ultra low risk prostate cancers. So there was clearly some over treatment going on. And, you know, as I mentioned, obviously, if you're going to have a prostatectomy for prostate cancer, there is some risk of incontinence associated with that, and a more important risk probably of erectile dysfunction associated with that. So what are the specific guidelines? So as I said, you know, they say to probably stop screening around 70. That's the COA guideline. It's hard to say because, you know, people are healthier, and patients that are actually alive at 70 years old now, their lifespan is not. So if the lifespan of a Canadian born today is, let's say, 78 and a male, or 79, if you are actually 70 years old and alive today, you do not have 8 years to live. You're probably around 18, 19, 20, depending on your smoking status and your morbidity status. So a patient who's 70, who's in good health, that cycles, that probably has 20 years ahead of them, I think that patient should get a PSA. A 71-year-old that's running all the time and eats well and does not smoke, that patient definitely merits a PSA. Of course, a patient that has all the, you know, diseases of metabolic syndrome, diabetes, high blood pressure, dyslipidemia, maybe has had a heart attack in the past, cognitive decline, that patient you probably would not want to screen because the competing interests are such that they're probably not going to die from their prostate cancer, and they're probably going to die from another disease paradigm. So how do we do the screening? Essentially, you know, we do a PSA. The thought process is, as I said before, if you have a PSA that's quite low, under 1, you probably don't need to be seen other than every 4 years. If your PSA is between 1 and 3 in that age group, you could probably wait 2 years. And if your PSA is more than 3, you should be screened every year. That being said, it's very hard for the patient to remember, and for our system, we don't function on a 4-year system, right? Our computers are based on 1-year outputs. Our rendezvous are given on 1 year, calendar years. So to organize to see a patient in 4 years is impossible for us. So the patient would have to somehow remember. And what we tend to do for most patients, if we are following, especially in Quebec, if patients don't have a family doctor, I will follow that patient. If a patient has a family doctor and their PSA is normal, I'll send them back to their family physician, but a lot of patients do not. And so we end up following a lot more patients than we would expect to. So what happens when the PSA is augmented? What do we do? PSA velocity, we don't really look at that so much, although it makes sense that if someone had a PSA of 1 a year ago and it was 2 this year, it makes sense that someone should think about prostate cancer. That being said, the idea of PSA velocity that was around 20 years ago, we thought it was very important. We now think it's much less important. It's really more the absolute value of your PSA, so the number itself, as well as PSA density is very important, and that makes sense as well. So a patient that prostate that has a mildly elevated PSA, let's say you have 100 cc prostate and your PSA is 5, which is technically elevated. So that patient would have what we call a PSA density of around 5%, 5 out of 100. So in that patient, although his PSA is mildly elevated in that large prostate, that's expected because, as I said before, a larger prostate secretes more PSA. So PSA density of 5% is not worrisome. We know from studies that the magic number is around 15%. So a patient that has a PSA density higher than 15% is at higher risk of prostate cancer, and in conjunction with MRI results, that goes up even higher. And as I said too, we can look at MRI results. I'll get to that in a little bit, but essentially MRI now is a standard aspect of our evaluation of the patient. And a nomogram, what does that mean? Nomogram is just essentially, it's an online tool that certain centers of excellence in the US have created, such as Memorial Sloan Kettering in New York. So essentially you'll put in a couple of predictors. So your age, your PSA value, if you have had a biopsy, what is your Gleason score? If you haven't had a biopsy, what did your MRI show? What was the size of your prostate MRI? And based on these 4 or 5 predictors, it can pretty accurately predict your risk of prostate cancer, and more importantly, your risk of high-grade prostate cancer. And I use these things all the time. There's a very good one from the European Consortium of Prostate Cancer Screening. And there's also another one, as I said, at Memorial Sloan Kettering, and other universities and centers have them as well. And their numbers may change a little bit because they're based on different patient cohorts. But what you try to do is look at a couple of them and see sort of like a median of where it's telling you where this patient's risk is. And based on these predictors such as PSA density, MRI findings, the nomogram, should you have a biopsy or should you not? And that's a discussion obviously with the patient. So how do we diagnose? So why a biopsy? So, you know, even if we think a patient has prostate cancer because of an elevated PSA, we need the gold standard. And the gold standard in medicine for cancer diagnosis is a tissue sample. And the tissue sample, here is a certain like a cartoon or a schema looking at how it's done. And this is the standard technique, which is called transrectal ultrasound biopsy. So essentially, the patient is on their side, and there's a biopsy probe that's placed in the rectum, and cores are taken from different aspects of the prostate. And we know now that it's probably best to do an MRI before doing this test. It allows a number of biopsies we do to decrease greatly if there's no disease on MRI. And even if a patient has a positive biopsy, that does not necessarily mean we are going to treat them. We may find low-grade disease, which I said before we would follow very easily. So what is the trajectoire standard de soins? So essentially in Quebec, we have a very good system for patient referral to specialists from family doctors, and that's essentially 2 PSAs that are elevated. So either a patient has a chez rectal, a digital rectal exam that's abnormal as judged by the family doctor, they would be referred to us, or a patient that has an elevated PSA twice. We ask them to do it about 6 to 8 weeks apart because we know about 25 to 30% of patients will have an elevated transitory PSA based on all the factors I spoke of before. And even if they have none of those factors, sometimes even just doing it from one day to another or from one lab to another, you can have a intra-variability from lab to same lab, and even inter-variability. So from 2 different labs, you can have different numbers. So you're going to get your biopsy, and your biopsy is negative. And of course, if your biopsy is negative, your question is, what do you do next? If you have a negative biopsy and the patient, you're worried that he does have a prostate cancer and he has not had an MRI, you would get an MRI. If he's had an MRI, which is normal, and a negative biopsy, of course, we would follow that patient with a PSA in about 3 to 6 months. A patient that comes out with a positive biopsy, so 2 things, either that it's positive, not risky, what we call ultra low risk or low risk, or it's intermediate risk or higher. And those definitions are pretty clear. So low risk is patients that we used to call Gleason 6. We now call it Gleason group 1. So the patients with 1 are at very low risk, essentially technically no risk of metastases. If the prostate sample from a prostatectomy shows 6, we know that patient can actually never die from their disease. That being said, a biopsy that shows 6 may not mean that the patient actually has only 6 in their prostate. And of course, a patient that has Gleason 7 or higher, and that's changing even now too, we're subdividing Gleason 7 into 2 groups now, into favorable and unfavorable. But up until about 2 years ago, we were treating all patients with intermediate risk, whether that be radiation or surgery. And there are some other alternative experimental treatments such as focal therapy. So again, to talk about the biopsy, the transrectal is the standard. It's been around now for 30 years approximately. It may miss a certain amount of cancers, the number 20%. Essentially, you're doing a biopsy through the anus. You have a good access to the posterior axis of the prostate, where classically the majority of cancers are found. However, a certain percentage, about 20–30%, are to be found in the anterior aspect. And because you would have to go through the whole prostate to get to those anterior lesions, obviously your sensitivity or your ability to detect disease when there is disease is diminished with this technique, and that's a known thing. As well, we can now target lesions. So if a patient has had an MRI, and that MRI shows a lesion somewhere in the prostate, whether that's at the part closest to the penis, which we call the apex, or the other part closest to the bladder, which we call the base, we can find that lesion on MRI, and then we can actually visually find it on our ultrasound and biopsy it specifically to have what we call a targeted biopsy. And of course, now we're starting in Canada of transperineal biopsy. The first person, or the first urologist in Canada actually published on this technique is Dr. Spivak in Toronto, who has over a couple thousand transperineal biopsies. There's not a lot of people performing them in Canada, just a newer technique. As well, it requires a specific biplane ultrasound probe. We actually are doing them now at our office the last 2 years, and what we find interesting is that there's essentially no infection. So the pain levels are probably the same. The bleeding levels are low, although technically it's less risky because there's no hole in the rectum. So if there is blood, it should be cordoned off in the area where the prostate is. But the big finding is really the because you're not going through stool. So obviously in the rectum there's stool, and when you go through that, you're introducing bacteria into the prostate, into the vascular system, and that's what can cause infection. So again, just to talk about the targeted biopsies, a targeted biopsy is essentially doing what we've been doing for almost every other organ for the last 50 years. So as an example, you have a lung lesion. You're not just going to randomly biopsy the entire lung in 12 different places. You're going to localize that lesion on CT. That patient is going to be sent to angioradiology, and the patient is going to get a transthoracic biopsy of that lesion if it's far from the bronchial tubes, and if it's near the bronchial tubes, they're going to get an endobronchial biopsy. So basically, you're biopsying what you think is disease, and that obviously makes sense. We haven't been able to do that for the prostate for the last 30 years because it's very hard to image the prostate. So standard CT imaging does not image the prostate well. It is not high enough resolution. So although MRI now has been around for about 30 years, the quality of the MRI and the ability to evaluate the prostate has only recently come of age over the last probably 7 years. And so now, as I said, we are able to do excellent imaging of the prostate. And based on that, we can find a lesion in the prostate if it does exist. And so what we can do is we can see where that lesion is. And as I said, we can transpose that lesion from MRI imaging to our ultrasound imaging that we're doing in real time on biopsy, and essentially biopsy the exact area of the prostate where we think the disease is based on the MRI, which is what we would do in any other organ. And the other way we can do it is, instead of just doing it where we see it on ultrasound, we can actually fuse in real time the images of our MRI that the patient has had with the real-time ultrasound with the probe that's in the anus. And we can actually specifically find that lesion very accurately and biopsy it directly to have what we call a targeted biopsy. So how long do the procedures take? It takes about 10 minutes, 10 to 12 minutes. There's a local analgesia. The probe is intrarectal. The standard transrectal ultrasound is 12 cores we take. So we take from 6 areas. So right apex, left apex, right mid, left mid, right base, left base. And we take 2 cores from those 6 areas. And with that, the idea is we think we have a good sampling of the prostate. And the reason we do that, prostate cancer, unlike a lot of other diseases, is multifocal. So even though you may have one dominant lesion, you may have other lesions. And the debate is still up whether those non-dominant lesions may biologically cause disease. And there's 2 major camps of thinking in urology. There's a large group that feels that it's multifocal, clearly that the dominant lesion is radiologically dominant, but biologically that are going to become aggressive and harm that patient, where there are others that fall in the camp that really the dominant lesion is the radiological one that we can treat with focal therapy. And this has not been resolved yet, and there's trials to support either group's viewpoint. Now, the biopsy results takes about 4 weeks, 5 weeks, and based on those results, we can give the patient some intelligent information. So just to brief you, if you were to undergo the intervention, of course, you would have to stop your blood thinners, which are NSAIDs and aspirin. Natural products we suggest as well to stop 7 days before, probably not as risky. Really, the risk we're seeing now are patients that are on the oral anticoagulants. So instead of having Coumadin now, the majority of patients that have atrial fibrillation or thrombotic events, have had a stroke in the past, those patients are all what we call oral anticoagulants, such as Xarelto and Eliquis and Lixiana. Those patients obviously have to be aware of bleeding, because those can cause much more bleeding than in a patient that does not take them. The day of the procedure, no need to fast. Probably a good idea to come with somebody, although it only lasts about 10 minutes. There's technically no sedation. Sometimes patients can have pain after the procedure. And we do give out antibiotics for the transrectal, but we've actually stopped giving out antibiotics now for the transperineal, and the rationale is because the skin is clean, it's not contaminated, and so if we prep it, there should be no bacteria there. So post-intervention, what do you suggest? Just avoid things that commonly make sense that would cause bleeding, such as things such in sports, alcohol, taking medications that could thin the blood. And obviously, various patients take various blood thinners, and the protocol with which you will restart those depends on the patient. Some patients are much higher risk of having an event with their thrombotic disease, and so those patients may get injectables on the next day after the biopsy, such as Inoheb or Lovenox, whereas others have a much lower risk, although they are on oral anticoagulants. Those you could keep them off for about a week after, and that really depends on the discussion between the patient, the urologist, and either the cardiologist or the internal medicine specialist of that patient. What are the side effects? So obviously a little bit of pain, and patients, it's not really for a few days. Generally, it's that day. Of course, the blood in the urine, the blood in the stool, or semen can occur. Doesn't necessarily have to, but can occur. And it's not worrisome to see it up to 6 weeks. As I said, the risk now of infection in Quebec is around 4% of transrectal biopsies. And we know that number because it's just based on the resistance to antibiotics. If you did stool samples of patients, their bacteria in that area, what would its resistance patterns be? It's around 4% now to Cipro in Quebec. So when do we suggest patients consult after having a biopsy? So the main thing is a fever. If a patient has a fever after a biopsy, they have to go to the hospital, not call the urologist, go to the hospital. Why? If a patient has a fever after biopsy, that means that they got an infection, a systemic infection, or a sepsis, and they clearly have a bacteria in their anus that is resistant to standard ciprofloxacin. If that's the case, they require very strong intravenous antibiotics to be treated, and that's not something that can be played with at home. It has to be done in the hospital. And of course, a patient that can't pee after biopsy, it really doesn't occur that often, probably around 1% or less, but can occur in a patient that has a large prostate. And of course, rectal bleeding. So rectal bleeding is on a couple of spots, but if there's some type of persistence of rectal bleeding where you put in a napkin and some type of Kleenex and you're constantly having to change it, or you see clots, that's a problem, and you need to go to the hospital as well. So I'll just comment on the disease score. So if you can see here on the left, what we classically called Gleason 6 has become a 1 over the last couple of years. And then the high Gleason scores have become 5. So it makes more sense. So someone that has high risk disease is a 5. Someone that has low risk disease is a 1. And the patients of 2 and 3 we consider intermediate. 4 we consider. And on the right is basically just a cartoon of what those glands would look like under a microscope if you were looking at it. But essentially, patients that have 1 have really glands that look like circles. Patients that are 5 are highly cellular, and patients that are in between have a combination of those 2 patterns. Just to give you a little quick on who would be treated. So the Gleason group 1s in Canada, we do not treat. You'd be hard found to find a urologist that would treat a 1 in Canada. In the US, active surveillance is taking on, but it really started in Canada. Actually, the urologist that started was a physician in Toronto, Lawrence Klotz. And so it has caught on quite easily in Canada, and all Canadian urologists follow Gleason grade 1. So Gleason or group 2, what do we do with them? So as I said, we used to only follow older patients or sicker patients with that disease modality. So someone who was 75 and 3+4, we'd say, we can follow you, but a young person we would not. Now we're starting to offer follow-up to patients that are younger, even if they have what we call a grade 2 or a grade group 2. And that's based on some data, not a ton, but some that comes out of Toronto that suggests that patients that have 3+4 look to parse out as those that have 3+3 in terms of their failure rate of active surveillance. So usefulness of imaging tests. So essentially, why are we imaging patients? So as I said, we're really using MRI now more and more. One is we want to diagnose the prostate cancer, and MRI helps us to diagnose it. Also, it may help us in deciding our choice of treatment. So, you know, a patient, for instance, that has a disease clearly on MRI that is outside the capsule and they have important pelvic lymph node disease, they're probably not the best patient to do a prostatectomy on, and they probably would be better served by radiation, where they could receive local radiation to the prostate and dogleg radiation to the nodes of the lower pelvis. As well, obviously, post-treatment follow-up. So imaging is used for follow-up with respect to disease recurrence. And we're able to see if there's spread, what the size of the tumor is. That being said, no one in North America would diagnose prostate cancer just with imaging and then do a definitive treatment. We do sometimes, based on imaging, without biopsy, treat older patients with systemic disease. But no one in Canada or the US right now would do, for instance, a prostatectomy or radiation without biopsy. That being said, there is a sort of a small trend, for instance, in Europe and Germany now, they're doing prostatectomies based just on what's called PSMA testing. So a patient that has a clear PSMA testing positive in their prostate, that patient would be offered prostatectomy in certain centers in Europe right now, which is really novel and completely experimental. So the usefulness of imaging tests, again, MRI is to look for the local lesion. So what do we know from MRI? Is there a lesion? If there is, what's the size of it? Where is it? Is it transgressing the capsule of the prostate? And if so, in what area? Is there rectal invasion? Is there not rectal invasion? Is it going into the area of the erectile nerves? That patient most likely will not have erections. Is there apical infiltrations that if we were to do a prostatectomy, we probably could not get a negative margin on that patient? And then CT scanning, so chest, abdominal, and pelvic. And what's interesting, we didn't really used to do chest scanning for patients at all with prostate cancer. The thought process was there was no skip lesions. We would just do abdominal pelvic scanning for bone metastasis and lymph node disease. We now know that actually patients can have skip lesions, which means that we don't see local lymph node disease, but we see distant lesions in the distant organs. So now, you know, the majority of us are getting thoracoabdominal pelvic scans, as well as we'll get a bone scan for patients that are high risk. Patients in general that are going to undergo radiation treatment for specific reasons, their literature is different. They will almost all get imaging for distant metastases, whereas urologists, we follow very specific guidelines that our literature suggests, and we will only do imaging in specific situations. For instance, if a patient, we calculate that their risk of lymph node disease is around 10% or higher, we will get them a CT scan. And if they are what we consider high risk, so just to go back here, these high risk disease, which is the grade group 4 or higher, they will all get bone scanning, those patients in our offices. Okay. So how does MRI work? So on your right, you see what an MRI looks like. Essentially, it's a tube. You're sitting on a gantry or a bed, and you're going into the tube. And it looks similar to a CT scanner. The technology is different. And the main difference is it takes a lot longer. So when you go into a CT scan, you're in the machine for about 15 seconds to about a minute or two. Whereas when you're on an MRI, you're in the machine for 30 minutes, 40 minutes, 50 minutes. And essentially the MRI is using magnets and radio waves to try and create 3D imaging of your organs. And of course, the organ of interest in our case is the prostate. So why do we get an MRI? As I alluded to before, CT scanning is not good for pelvic imaging, and specifically prostate. It is not high enough resolution to allow us to see lesions within the prostate. The MRI allows us to find a lesion that we may target on biopsy, either transrectal or transperineal. If we do find a lesion or a cancer, we were able to see if it is spread locally, either transgressing the prostate on the side, at the apex, at the base, and even we can identify lymph node metastases on that MRI as well. And of course, we do not use the MRI ourselves to look at pre-treatment planning, but in radiation oncology, they definitely use a pre-treatment MRI to specifically guide their treatment. And of course, also patients, for instance, that are on active surveillance, those patients We used to all surveil them with PSA and DRE every couple of months for a few years, and then once a year forever. And we would get a biopsy them once a year, every year. And this is when we started active surveillance about 10, 15 years ago. Now we've stopped doing really a lot of these biopsies. We do probably one or no confirmatory biopsy, and then we follow PSA and our DRE. And of course, we can also use MRI to follow the patient. So for instance, if we have a patient that has a lesion MRI about 1 centimeter, we biopsy it, it comes back as Gleason 6, their PSA is stable, we follow them, their PSA doesn't move. We may elect to get an MRI in a year or two and see what has happened to that lesion. So if, for instance, that lesion has grown or there's a new lesion, we may elect to redo another biopsy either in that growing lesion or in the other lesion that is novel. So we're able to better follow patients that have already established prostate cancer. As I said here, about 30, 40 minutes, you have to stay still. If you do not stay still, the image quality is very diminished. That's important. So certain patients are claustrophobic. They cannot have an MRI. It doesn't work well. There are some MRIs in private and a couple in the public that are what are called open bore. So you actually sit there and it's not closed like that, but that's not common. Obviously, also patients that are larger may have more problems of claustrophobia and even fitting into the machine, but there are machines that can accommodate anybody of any size that are available. Another thing that's happening now is the reason why the MRI also takes long is we inject patients with a dye called gadolinium, and we thought that it was helpful about 7-10 years ago for helping us find lesions of the prostate. We now know that it's really not that helpful. The MRI itself is very useful, but the phase of adding gadolinium and then looking at the effect of gado on the imaging does not help that much. And there's a trend now to stop giving gado and to just do an MRI without it, which shaves about 10 to 15 minutes off the test. So what are the contraindications of MRI? I mean, probably, a lot of people have had an MRI for your back or anything, but the big ones are pacemaker, an auditory in the auditory canal to have a sensor there, and as well a prior allergy to gadolinium, which is rare. So as I said, the pacemaker, cochlear implant, and of course the one I missed, patients that have metal in their eyes. So metal in their body is okay, but specifically if they've had shrapnel or for any other reason, metal in the globe of the eye, that is technically a contraindication absolutely to MRI. That's basically it. You're going to maybe empty your stomach, and you're not going to drink any liquid. And certain clinics may ask you to rectal enema and others may not. So the results. So the MRI results is a very good reproducible system used globally for MRI reporting now. It's called the PIRAD system, and this was created by the radiology associations. So very similar to the Gleason grading of the histology of the cancer. This is looking at the radiological grading. So is there a lesion or is there not? So if they give you a score of 1 to 2, there is no lesion. If they give you a score of 3, it's equivocal. The risk of someone having a significant prostate cancer with a 3 is around 15–20%, so quite low. However, if you have a PIRADS 4 lesion and MRI, your risk of having significant cancer is around 60%. And if you have a PIRADS 5 lesion, your risk of having prostate cancer is around 80%. So I think we just spoke about that. And what I'll update to tell you here is, the US, before even the guidelines were telling people this, especially in Europe where MRI is quite easily available, everyone was getting MRI pre-biopsy. And this started this trend in England where they did 2 trials to look at the utility of MRI before biopsy. And the rationale is that you should be able to see a lesion that's significant. And they were able to show in this trial called the PROMISE trial that they could reduce biopsies about 30% and increase the number of significant cancers they were finding and reduce the number of insignificant cancers they were finding. So England was way ahead of the curve. And essentially in England, if you have a normal MRI, you're not even going to get a biopsy. MRI is hard to get in Canada, but it's also hard to get in the US. So MRI has been a little slower to get on in both countries. That being said, it's been standard of care now to do an MRI before a biopsy in the US now for about 5-7 years. And in Canada, we've been wanting to do it for the last couple of years. Our problem is access. So to get a prostate MRI, depending on your center, where you live in Quebec or where you are in Montreal, can vary greatly. Like I can tell you, in my hospital, it's about a year. Unless you write urgent, and the patient has a PSA over 20, it's a long time. Whereas other hospitals may be shorter. And of course, there's the private where patients, but ideally, every patient should have an MRI before, and that's based on data from trials from England from 7 years ago. That's based on AUA guidelines, which is the American Association of Urologist guidelines from about 2-3 years ago. And now just recently in 2022, the Canadian Neurologic Association lended credence to this notion that we should be getting MRI before biopsy, to avoid biopsies we don't need to do, and also to better guide our biopsies to target lesions if they are there. Because if we don't have an MRI pre-biopsy, we're just randomly biopsying. So I'll give you an example. A patient may have a large tumor in their left apex. However, when you did your sampling, you got all the areas, but you didn't get a great sampling of left apex, and the needle just happened to not go in that lesion. That patient, you would tell them they do not have cancer. Yet if you were to target that lesion with an MRI target post MRI, you would find the cancer. You would say, hey, there is something there. So really, we want an MRI before, and we're slowly getting better access, but it's really an issue of accessibility and healthcare at the governmental level rather than a medical issue. So what is a CT scan? As I mean, everyone knows what a CT scan is. You go in a machine, they're sending x-rays, they're able to build 3D imaging of the organ of interest based on the ability of x-rays to pass or not through the tissue. The main utility why are we using CT scanning is just to look for metastatic disease, whether that's your pelvic CT to look for lymph nodes in the pelvis, or that's your abdominal to look for your high retroperitoneal nodes, or you may want to be looking for lesions in the liver or the lungs. That's what the CT scan is for. And CT scan is very easily available. I mean, when we write that a patient has a cancer and they need CT scanning, that's quite easy to get. We can get it within 2 to 3 weeks easily. Very different than MRI. CT scan, the duration, it's not 15 to 30 minutes. I don't know why it says that. It really, you're actually in the machine usually for 2 minutes, 3 minutes, even 30 seconds. If there's a late phase for specific imaging, it may be 10 minutes, but for imaging with contrast, you're literally on the gantry for about 1 minute, that's it. And you're lying there and they're gonna give you contrast agent. And a patient that may have renal issues, we may not give contrast, but we try to give contrast because contrast allows us to much better see whether there's lymph node disease or not. The thing patients have to be aware, a lot of patients will tell you, I have an allergy to iodine, but the majority do not. So this feeling of like a hot flash in your body when you get a CT scan is not an allergy. The flushing that you feel, a metallic taste in your mouth is not an allergy. The only time someone has an allergy, 2 things. If they have a rash, it's a low-grade allergy, they can still undergo CT scanning and require some preparation. Patient that has what we call anaphylaxis, so swelling of the lips, swelling in their mouth, inability to breathe, sudden feeling, dizzy, and actually having objective low blood pressure. Those patients have a severe reaction and cannot undergo CT scanning with iodine. So of course, when you do CT scanning, you do need a blood creatinine, which is just essentially done to assure that your kidneys are of good quality so that you can undergo the injection, because iodine is risky in patients that have kidneys that are not very functional. Fasting 2 to 4 hours, sure. So the bone scan. Basically, when we order it, as I said before, if you're going to undergo radiation oncology treatment, almost 100% of patients are going to get that test. That's what I see. However, if you're going to see a urologist, it's going to follow the NCCN guidelines. So patients are only going to get bone scan if either they have a PSA of 10 and a lesion on the prostate, so you feel it. So when you put your finger in the anus and you do your digital rectal exam and you feel a lesion and their PSA is more than 10, you're going to bone scan those patients. If they have a PSA of 20 or higher, they're going to get a bone scan, because your risk of having bone scan disease with a PSA of 12 or 13 is basically 0. So there's no reason to get all these tests if you don't need to get them. A, there's a cost to society. B, there's a risk of undergoing a procedure. C, you can get false positives that you have to deal with. Bone scan procedure taking about 3 to 6 hours. Essentially, they're injecting a radioactive tracer that's going to go to your bone, and it's going to go to any area where there's a growth or a sudden high turnover of bone growth, which is compatible with a bone metastasis, since prostate cancer causes what are called blastic lesions. So if someone has bone disease in the context of cancer, there's two main types. There's lytic, where there's actually bone that's destroyed, and there's blastic, where there's bone that's built, and that bone that's built is the classic of prostate cancer. Bone scan preparation, there's really nothing to do. Bone scan results, you're going to get them, and if there's hot spots, sometimes it's equivocal, sometimes it's unclear. Sometimes if it's unclear, the nucleus may say redo it in 3 months, but we can't wait 3 months. We need to treat this patient. So we may elect to do a CT scan or an MRI of that region of interest to corroborate whether there actually is a lesion there or not. And sometimes even after that, we're not sure. What do we do? 5, 6 years ago, we had nothing. Now we have PSMA testing, which I'll talk about in a little bit, which really helps us to find if there's a true metastasis there or not, which can help us in specific rare cases where the metastatic workup is equivocal. So what is PSMA? So PSMA is a type of PET scan. So the standard PET scan essentially is you're injecting a radioactive molecule, and it's connected to sugar. So the thought process is that sugar is taken up highly by the majority of cancers, and if it's taken up in a lesion, you know there's cancer there. Prostate cancer, however, does not absorb a lot of glucose, so it does not take up PET. So PET has never worked well for staging and imaging and evaluating prostate cancer patients. However, PSMA, which is prostate-specific membrane antigen, is a protein that's on the cell of all prostate cancer cells. And the thought process here is that you can attach this radioactive product to the PSMA ligand. So essentially, they're able to build a synthetic molecule that looks like the molecule that's on the prostate. And so that radioactive substance will go to all the prostate cancer cells in the body. So it's like PET, but instead of looking for sugar uptake, it's looking at the so this is injected, and it's injected with a radioactive product, which is the gallium-68 PSMA. And the test is technically, it's approved in Canada. That being said, it's not widely available. It is available actually in and around Montreal in a couple of centers, what we call quote unquote an experimental basis. So its funding is not truly through standard healthcare funding, but it's funded through what are called research or clinical research protocols. But a lot of those protocols are open to patients that have prostate cancer. So we can get it depending on the indication. It is available and it is very helpful. These are just a couple of false positives of PSMA testing. We don't need to know those. And these are just different suggested indications for PSMA utility. I can tell you very simply, when do we use PSMA? In some centers, they're using it to stage every patient that has high risk disease. So a patient that has Gleason 8 or higher is going to get PSMA testing. I know, for instance, the Jewish had a protocol for PSMA testing for Gleason 8 or higher. And the thought process was, would it change management? So patients that we thought were local, would they become metastatic? And now we suddenly treat them as metastatic. The thought process is not so much that's the best utility, although that's experimental. It's very useful, I think, in two specific clinical entities. One, we have a patient that needs to undergo definitive treatment, whether radiation or surgery, and they have an equivocal metastatic workup. As I said before, PSMA can really elucidate and clarify that in almost all cases. And the second is really the most interesting, where we're using it right now, is in the post-treatment follow-up. So a patient, for instance, gets a prostatectomy. Their PSA a year later is 0.1. The thought process that we always learned was based on kinetics. So if a patient had a high PSA rapidly post-op, they were considered metastatic. If a patient had a slow-growing PSA post-op, and later on we considered them local recurrence and gave them radiation. We know that's not really the case, and that's just based on trials and predictions, but not on true findings. So what we used to do is, when it had a PSA rising, we get a CT and we get a bone scan. The problem is CT and bone scanning are not sensitive enough. So you may have cancer in the body and you may have a PSA of 1, but your CT is going to say there's nothing and your bone scan is going to say there's nothing. However, if you do a PSMA, you're going to find disease. So a patient that has a PSMA, I can give you the numbers here. So a patient that has a PSMA that is, for instance, 0.2 to 0.5, you're going to find 55 to 60% of cancers. And if their PSA is up to 1 to 2, you're going to find 100% of cancers. So patients that we knew had recurred, we knew there was disease, we knew there was something somewhere, we see it with CT, bone scan, now we're seeing it. And what's the advantage of that? We used to, if a patient had a recurrence, we just said, okay, give you hormones, that's it, follow you. But now there's so many different levels of treatment, in addition to systemic treatments, but also we're starting now, which is quite new, to treat, locally treat recurrence. So for instance, a patient has a prostatectomy, they recurred 2 years later, they have a bone scan and a CT scan, they say there's nothing, but we know there's something, we PSMA them, we find a lesion, let's say on a bone, and in one area or 2 areas, we can radiate those 2 areas specifically. Why? We radiate them and now we can try to potentially, I mean, not necessarily cure them, but give them a year or 2 without hormones and prolong their life. Now, maybe in a couple of years, we will be able to cure them. We don't have that data yet. But the idea is that we only have 2 areas of disease. We can radiate it directly, try and kill those cells, and follow that patient without hormones. So this is just imaging of a patient showing uptake of the PSMA in the chest, demonstrating the presence of chest disease in the context of this patient with prostate cancer. So the medical monitoring and PSA, as I said before, not a great test. It's a good test, not incredible in the pre-operative or pre-radiation oncology. However, in the post-op, it's amazing. So if a patient has a prostatectomy, their PSA goes to 0. If the PSA rises, we know there's something. It's very, very specific and sensitive. So if a patient has a PSA of 0.5 and had a PSA of 0 a year ago, they 100% have a recurrence, and it's an excellent test, and we just have to figure out where it is. And that's where CT scanning and bone scanning and PSMA comes into utility. And these patients, we try to follow them for about 10 years. There are some rare occurrences of late recurrences 20 years later. However, the rarity allows us to not follow all those patients. And we follow all our patients up to about 5 years. And then obviously if they live far away, they may be followed by a family physician, but if they live locally, we follow them out. And as I just mentioned to you in the other slide, it's an excellent test. And obviously a patient that's having a rapid increase in their PSA post-op is most likely having a rapid biological recurrence and most likely metastatic disease as well. So this is just a little diagram showing that a patient has a diagnosis. I'm trying to move this to see it here. They have a diagnosis. They have a PSA of, let's say, 6, 7, 8. We operate them. Their PSA goes to 0. They may get a bioclonal recurrence where their PSA goes. Now, 0.2 is an old number. We used to use 0.2 about 7, 10 years ago. Even before that was 0.4. Now our definition of recurrence post-prostatectomy is 0.1. So a patient has a 0 PSA. If their PSA goes to 1 and rising, they have a recurrence. However, if they've had radiation treatment, that definition changes. The technical definition of recurrence in a patient that has had prior radiation is their nadir. So if their PSA was 5 and after radiation went down to 1, if it goes up to nadir plus 2, so 3 in this case, they are considered recurrent. And those patients would go on to have some type of treatment for their recurrence. The other treatment that also many patients undergo is brachytherapy or curie-therapy. One of the only things we do see with that treatment is that some patients, specifically young men, have what's called PSA bounce. So they may have the treatment, their PSA go down, then come back up, and then go down again. So you just have to be aware of that fact, that your PSA may bump up and then may come down again. And that phenomenon is not well understood, the physiology behind it. We know it does occur. So if someone has a PSA rising after radiation, pure or surgery recurrence, if someone has a PSA rising after brachytherapy, there may be some element of PSA bounce, and that has to be tailored to the patient. So as I said before, nadir and then the nadir going up. This diagram is showing that idea that if the PSA rises above nadir by 2 points, there's a problem. So if your doctor has recommended hormone therapy, So if your doctor has recommended hormone therapy, you're going to follow that with PSA. And if you're on hormones and your PSA does not go up, that means technically there's no recurrence. There are rare cases where the patients have a PSA that does not go up, but they do have progression. That's in a type of prostate cancer, which is called neuroendocrine, and we cannot follow that with PSA. So some patients, less than about 1%, who have a controlled PSA, that have a testosterone that's controlled through their hormonal manipulation, will have neuroendocrine transformation of their prostate cancer and will have progression. And that's why we actually follow all patients, even if they're not progressing with PSA, they should at least have a bone scan about once every 6 months to a year, even if their PSA is not moving, just to be sure that they're not having what we call adenocarcinoma progression, which is the majority of progressions. So this is just a great slide that's really messy, but just really shows how incredible prostate cancer research has been over the last 20 years. So I can tell you, I started residency in 2004. Before 2004, there really had not been anything in prostate cancer systemic in 60, 70 years. So hormonal manipulation was discovered by Huggins in the 1940s, and they knew that patients that had prostate cancer, if you could stop their testosterone production, you could render their disease slower. And nothing happened for 50, 60 years. And then patients were using mitoxantrone for prostate cancer in the late 1990s. In 2004 was the first trial specific to prostate cancer, which is the TAX 327 trial. And since that first trial in metastatic disease, there's been over, I mean, this is just showing you which ones are approved, but there's been hundreds of trials, and now we have about 7, 8 agents that we can use in prostate cancer, even in combination or sequentially, at different levels of the prostate cancer. For instance, a patient that has metastatic disease that we treat, if that disease progresses, we may consider adding on a chemotherapy, or if they've already had chemotherapy, we can give them a hormone manipulator. Even now we have a very fascinating treatment called olaparib. So patients that have a specific genetic change in their DNA would be eligible for this treatment if they failed one treatment and were metastatic. They would be eligible for this treatment, which is specifically tailored to someone with a specific genetic makeup. We also have medications that stop the production of testosterone, such as abiraterone. We have medications that interact with testosterone and its receptors, such as darolutamide, apalutamide, enzalutamide. And they all have their benefits and their disadvantages, and some are easier to take than others. But what's been truly incredible is the speed with which research over the last 20 years has allowed these agents to come out, which has revolutionized prostate cancer. So in 2004, if you had metastatic prostate cancer, your lifespan was about 2 years. If you have metastatic prostate cancer in 2022, your lifespan could be 5 to 7 years. So a huge difference. So I think that's it. What I would say, if you could get 2 messages from this, if you could get 2 messages from, if you get 2 messages from this presentation, would be A, MRI should be used pre-treatment to find out if you have a lesion. If you do, where is it? And the other type of imaging would be PSMA, which may be really used in the post-treatment paradigm. And if you're going to get metastatic workup imaging, that would be your CT scan and your bone scan preoperatively. And those are really the 4 tests you're going to use, and those are the main areas with which you're going to have them done. Thank you.
Well, thank you so much, Dr. Lewinshtein, for this excellent presentation, thorough presentation. We will now open the question period. This gentleman is asking the following question. I am 72 years old, and my doctor told me that past my age, there's no need for screening, that I would die of something else. I'm worried because a friend of mine, he's 77, has aggressive prostate cancer, which he told me. Should I be worried?
So yeah, I think if the patient has had a prior PSA and the PSA was normal, and the patient was worried and the patient was healthy, and that was a patient that was going to live, another more than 10 years, I would get a PSA from that patient. I mean, the CUA tells you two things. They say you could stop around 70, but they also say if you have more than 10 years life expectancy, you can offer it to that patient. So in a healthy patient that is worried about that, I would draw a PSA. And I would allow them to see where that PSA is and then get another PSA. And if the PSA is normal, consider following it until about 75. And if the PSA is abnormal, we'll proceed with diagnostic testing.
Interesting question here. Can PSA levels vary from lab to lab? Should blood tests always be done at the same lab at the same time of day?
Time of day, I don't know, but lab, yes. So there actually are different ways to assess different assays that different labs use to assess the PSA. And they change, for instance, I know at our hospital, the assay changed a couple of years ago. Biopsy, which is one of the big private providers on the South Shore in Montreal as well, I think, their assay changed about a year ago. And we noticed there was differences in PSA levels. So we had to be advised of that. And they actually specifically said it on their reporting that there was a different assay. And so, yes, I would ideally recommend if you're going to get PSA testing would be in the same place. I don't necessarily the same time. There's no difference in that. It's not like testosterone that it peaks in the morning, but ideally the same lab, and just be aware that if there's a change in their assay, and that's usually printed on the report page, to take that into consideration in the evaluation of the number.
Okay. This gentleman, my PSA level was 5.8 when I was scheduled for a biopsy. It's at 4.3 now, and the digital rectal exam is normal. So can I cancel the biopsy? I'm 62 years old.
So 62-year-old, we used to kind of use the number, the grab number of 4. In Europe, it was 3. We get a biopsy. We know that PSA levels are different based on your age group. So a patient that's 62, you can kind of allow that 95% of patients from 60 to 70 will have a PSA up until 4.5. So if that patient's PSA has decreased, I would consider following them and then doing an MRI if it did go above 4.5. Because technically 4.2 is normal. So if you have one PSA, you redo it and it goes down to 4.2 and he's 62, I would not worry about that patient. No, I would follow him with another PSA in maybe 7 months. And if it rises above 4.5, then do an MRI.
Let's move on to the biopsy and MRI section of the questions. Now, why do some urologists prescribe an MRI instead of a biopsy to assess and or ascertain the presence or progression of prostate cancer? Some others prescribe both exams.
So I think, there's different things involved. There's a question of, when you trained. I've wanted to ask for MRI for the last 5-6 years pre-biopsy, and that's what we want to do because we know that's probably the right thing. Guidelines in Canada only projected that this year. So technically, for instance, if you got a test and someone said, why did you get that test? It's not recommended. The doctor say, I'm not sure. I thought it was right, but the guidelines said no. So that may play an aspect into the physician's head. 2, the main thing is accessibility. So access to MRI is challenging probably all over Canada, but specifically in Quebec, although we do have the alternative of private. It's hard to get a prostate MRI, like I said, the wait times vary between 3 months to a year. So sometimes they may say, you know what, I can get this biopsy done in my office in the next month. MRI may take a year. If they do have prostate cancer, they may wait. So that may be another thing in their head. The other thing that may happen, if you have a PSA, a guy has a PSA of 30, 40, very high, you're probably, if you can't get an MRI quick, you're going to skip that MRI and you're going to get the biopsy ready because there's a prostate cancer there when it's so high if there's no reason to think they're infected. The other thing, of course, if you do a DRE and there's even a large nodule or a rock hard prostate and your PSA is 10, let's say, or higher, this guy for sure has prostate cancer and you're just going to proceed to biopsy and you can avoid that MRI because you know that their disease is probably locally invasive. So you're not looking for a small lesion on MRI.
Good. So why not go with an MRI to confirm or not the presence of cancerous cells? And then, if still necessary, carry out a very targeted biopsy in the identified area or areas.
That's the ideal. So that's the ideal, is getting the MRI before. and that's what we should be doing. And that was contemporary for the last 7, 8 years in the US, guideline recommended in the US since around 2019, guideline recommended in Canada only since this year. And those guidelines were really based on taking into account, could we even get an MRI for our patients if we wanted it? But yes, that would be the ideal. Get an MRI. Is there a lesion? If there is a lesion, target biopsy that lesion. If there's not a lesion, then discussion with the patient based on what is their risk of prostate cancer with a negative MRI. The overall number you can retain from trials are if a patient has a normal MRI and a PSA between 4 and 10, their risk overall is around 10% of having a significant prostate cancer. However, we can actually make that number more specific just by looking at the specific predictors of that patient. Like I alluded to before, we had nomograms. We can actually put in the age, the MRI size, the PSA, and have even a more accurate number of what that specific patient's risk is. So I do it all the time. You know, you got an MRI, there was no lesion, you're 60, you have a PSA of 2, your specific risk of having Gleason 7 or higher is 3%. If you can accept that risk and live with it, no biopsy. If you really have to know 100%, biopsy.
Okay, so Dr. Lewinshtein, you talked about prostate biopsies by fusing multiparametric MRI images with live, real-time ultrasound images of the prostate. Why isn't this the norm in Quebec?
It's cost. It's what we'd like. It's cost. It's a pure cost issue. You know, the imaging system costs between $200,000 and $400,000. The guidelines, we always allude to guidelines because governments make decisions not on whether I call them and say, I want this test. We have to have some type of proof. So if we submit like what's called développement in Quebec, if you want a new technology, if you're not replacing something, you have to have that développement backed by guidelines, something specific objective. And the guidelines in Canada up until this year were actually to just do an MRI post biopsy if there's persistently elevated PSA with a negative biopsy. We wanted to, as a group, to have it done pre, but the access is challenging. I repeat that statement. And so if there's no proof that it works well and we don't have the money to buy it, it's hard to do. Ideally, we would have it in every hospital, as you suggest. It's just a cost issue. And it's probably a little bit of a training too. You know, if you've never done it before, you have to get used to it. It's a learning curve. But really, it's the cost to obtain the technology.
And I'm absolutely certain that you want to go with the 400,000 cost than the 200,000 cost because of the quality of the equipment, I guess.
Sure.
Get it. In 2015, this is a good question. In 2015, I was diagnosed with cancer. Gleason 6, 3 plus 3, in 5 cylinders, infiltrating from 5% to 65%. Under active surveillance, the results of 2 other biopsies plus an MRI in 2019 are negative. So my question is it common that a first biopsy is positive and the other is negative? I'm 77.
Yeah, I mean, so if he's 77, he has that disease that is not worrisome, Gleason 6 multi-core, as we consider low risk, not worrisome, just off the bat to say that. 2, is it possible? Yes. So when we do that, so the patient that had this positive biopsy and then had a negative biopsy. Continue or yeah?
Okay, just finish your answer and I will conclude after that.
Oh, okay. So I would just say, yes, it is possible to have a negative biopsy because if you sampled one specific anatomical area with your biopsy in 2019, right, and then you went back to your biopsy, you cannot go back to the exact same area where that needle was. You're just going to put the needle in somewhere. You're not going to be in the same place. Maybe that place doesn't have the cancer in it, which the other place did. You're going to say there's no more cancer. It's not there's no more cancer. There's just no cancer in the area where your needle was. And the reason why your MRI is negative is because the cancer you biopsy, what's called microscopic in 2019, it wasn't big enough, the focal lesion, to be visualized radiologically, but it's there biologically at a small scale.
That's what I call good news. Listen, we're coming to the end of this webinar. We've overrun a bit, and but all of this is so interesting. So once again, a huge thank you, Dr. Lewinshtein. for your precious time. It's extremely appreciated. Outstanding questions will be answered, should I say, individually. So we wish to thank all of you for participating, our guests, speakers, presenters, and partners for supporting us through the year. Our next webinar will take place in January 2023. So until then, call us or visit procure.ca to stay up to date, and best holidays to all. I'm Winston McQuaid. So for Procure en Parle, looking forward to seeing you again. Good evening.
Thank you.
Vous avez aimé les services de Procure? Alors n'hésitez pas à contribuer à procure.ca. Merci pour votre générosité.